Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another podcast. Joining us today is Dr. Jeremy Heiner, respected academic and clinical faculty at Kaiser Permanente School of Anesthesia, where he's been shaping future CRNAs since 2008. His academic interests include airway management, crisis response, respiratory physiology, critical events, and simulation-based learning. He's also served extensively on the NBCRNA, contributing as both a committee member and chair. Beyond the classroom, he's one of the 3 CRNAs behind the education platform, The Nurse Anesthesia, which you can find at thenurseanesthesia.com, a growing resource hub supporting SRNAs and practicing CRNAs alike. Today, Dr. Heiner joins me to talk about IV induction agents, how drugs like Propofol, Etomidate, and Ketamine work, and how to select the best one for each patient, and what every anesthesia learner should know to safely and confidently plan their anesthetic. Let's get into it. Hello, my favorite learners. Today we are talking IV induction agents with Dr. Jeremy Heiner. He is the head of admissions at Kaiser Permanente School of Anesthesia, as well as clinical faculty. So thank you, Jeremy, for being here.
Chloe, thank you so much for having me on the show. I've been looking forward to this.
So we're going to start with how I kind of start every podcast, and I just want you to talk a little bit about how you ended up in CRNA education and maybe mention some mentors along the way and things like that.
Sure. No, number one, I love being an educator. I've been an educator for about, I'm kind of embarrassed to say it, but it's about 17 years now, and it does not seem like that long ago that I started in education. So I graduated anesthesia school, took a job at Kaiser Permanente here in Southern California at one of their major medical centers, at the same one you work at. It was a few years after that one of my mentors at the time, Dr. Sass Elisha, invited me to teach an airway class at Kaiser Permanente School of Anesthesia. And it was challenging, it was scary, it was anxiety producing when I was up there in front of everyone, and I loved it. And I must have said something right because they invited me back the next year. I don't know why, but I'll take it. And they gave me another lecture, and then a couple years later, a part-time position came open, which I threw myself at, was super excited. And another one of my mentors, Dr. John Nagelhout, he's actually the one who hired me to teach as a professor at Kaiser Permanente School of Anesthesia, and I've been there ever since, now full-time faculty, and still enjoying it, still loving it.
Yeah, and having both you and Sass in class, as I graduated in 2016 from Kaiser Permanente School of Anesthesia, it's just so amazing to see the evolution of it all. You went through, and they were your mentors. Art Gabbett went through. You guys were his mentors. He was my mentors, and it's truly that concept that Sass and I talked about actually when we recorded our podcast, how the mentorship trickles and just continues, the ripple effect forward. And I hope anybody listening to this gets inspired by hearing these people speak to their journeys in education, as well as mine as I venture into the academic world, and can see what they can do within themselves when they become CRNAs. So thank you for sharing your experience.
My pleasure. I always look at it from the perspective of my philosophy in teaching is my students, they're my students at one point, but they're my future colleagues, and I'm going to be working with them. So you mentioned Mark Gabbett, worked with him for years. I remember when you graduated, just like my own graduation, it does not seem like that long ago. Yeah, it's pay it forward, because you never know what's going to happen in the future. And here we are doing a podcast in 2025 together.
Yeah, and I always share with students, anesthesia is such a small world, especially nurse anesthesia. You could end up in Montana and run into somebody you went to anesthesia school with. I mean, it is that small of a world. So giving back, paying it forward, and being kind are fundamental in nurse anesthesia is what
Absolutely.
I say. So we're going to dive into the mechanism of action of our 3 top IV induction agents. So Jeremy, can you talk a little bit about the mechanisms of action of our big 3? So that's Propofol, Etomidate, and Ketamine.
Yeah, let's get going with this. So, and this is going to be a specific focus on induction agents, and certainly all of these medications that we're talking about today can also be used for procedural sedation. In anesthesia, we primarily use these as induction agents. So I'm going to start out with talking about a neurotransmitter called gamma aminobutyric acid, or GABA. Everybody's heard of GABA. So an understanding of this particular mechanism is very, very important, because this is the neurotransmitter that, or the receptor that both Propofol and Etomidate work on. Now, I know we're not going to talk a lot about barbiturates today, but they also work on this particular receptor. So what is GABA? And again, that's gamma aminobutyric acid. It is an inhibitory neurotransmitter, and it's in the central nervous system, so it's in the brain. What it does is it helps maintain homeostasis. So you have neuroexcitability and neuroinhibition. And the brain has neurotransmitters, they have chemicals in the brain that help maintain a balance between that. So GABA acts as a crucial regulator in the brain, and it helps prevent overstimulation. So it's more of an inhibitory neurotransmitter, and ultimately what it's going to do is it helps promote relaxation, sleeping, and again, it's that balance. GABA being an inhibitory neurotransmitter, the excitatory main neurotransmitter in the brain is going to be glutamate. And that's going to be working on something called the NMDA receptor. We'll get to that in just a little bit. So in terms of the GABA receptor, there are several types of GABA receptors. There's the GABA A, the GABA B, the GABA C. And the GABA A receptors, they're known as ionotropic receptors. That's a big word. Maybe you're going to remember it, maybe you're not. But what it means essentially is GABA A receptors are ligand-gated receptors where they work on ions. They work with ions. So when GABA works on a receptor in the brain, it's going to open an ion channel, specifically chloride. And it's going to let chloride go into the cell, essentially causing a hyperpolarization of the cell. And that makes it so that cell is not going to fire. It's not going to be excited. And we're going to feel more relaxed. If you're talking about GABA B receptors, those are called metabotropic receptors. And they're also in the central nervous system. However, the drugs we're talking about today, the induction agents, they don't work on that receptor. Now, just to further add, if we really want to get down in the weeds, which we're not going to go there very much, but in order to distinguish between the various induction agents, all of these GABA A receptors, they have different combinations of protein subunits. So they have subunits, and you could say they're alpha, beta, gamma, delta. There's like 19 of them. I'm not going to name them all. And so essentially, Propofol is going to work on some of them. Etomidate is going to work on some of these GABA A subreceptors. The barbiturates would work on those. Our benzodiazepines will also work on these GABA A subunits, on the different ones. So that's how, at the cellular level, these receptors can differentiate between the medication molecules, because they're working on these different subunit receptors. So there you go with GABA. So that's GABA. And again, Propofol and Etomidate are going to work on that GABA A receptor, and specifically subunits. All right, so now let's talk about ketamine. Ketamine inhibits glutamate. So ketamine, how that works is it is called an NMDA receptor antagonist. NMDA stands for N-methyl-D-aspartate. So NMDA. And this is a subtype of a glutamate receptor. So the molecule glutamate, the neurotransmitter glutamate in the brain, is going to work on this receptor. Glutamate, like I mentioned, is a major excitatory neurotransmitter in the CNS. So again, we need this combination between GABA and NMDA receptors in order to maintain balance in the brain. If there's more of one than the other, we can be more excited or we can be more inhibited. Now, ketamine acts as a non-competitive antagonist of the NMDA receptor. So again, it blocks glutamate. So it's going to ketamine will bind to the NMDA receptor ion channels, and it'll block that glutamate. Usually when glutamate attaches to these channels, it's going to let in calcium, it's going to let in potassium and other ions. Now, one thing that ketamine does when it attaches to these receptors is it causes a condition called dissociative anesthesia. And what dissociative anesthesia is essentially a dissociation or disassociation. You can use those words interchangeably. And it's that dissociation between the cerebral cortex of the brain and the limbic system, so the emotional side of the brain. So it's going to depress the cerebral cortex, but it's going to stimulate the limbic system. And that's why people will have something called emergence delirium, which is essentially alterations in mood, body image, vivid dreams, illusions, hallucinations. They can get anxious, they can get combative, they can get very scared. So a lot of it is dependent on the environment that they're in. And when we talk more about ketamine, we can talk a little bit more about that. So that's essentially the receptors that these three induction agents will be working on.
And I remember Dr. Nagelhout. So Dr. Nagelhout taught us pharmacology, and he used to always say, or joke, I should say, that if you guess GABA mimetic for the IV induction agent's mechanism of action, you're probably gonna be right, just statistically speaking, besides that ketamine.
You got a really good chance of getting that right.
Yeah, exactly. GABA mimetic, which we talked about mimetic meaning that it promotes it, right? So GABA mimetic, just in case nobody knows what mimetic means. So we also talked a little bit about earlier before we started recording about barbiturates and how I've used it. They're not very commonly used, but I did use it in training doing electroconvulsive therapy for mood disorders, other indications for that type of therapy that they still do, because barbiturates lower the seizure threshold. So we used Brevitol back then for them, but just, I guess, a little bit of a tidbit that Propofol is an anticonvulsant, so that's why we have to still use Brevitol in some instances like ECT therapy to get the seizure threshold lowered to actually get that therapy completed.
Barbiturates, you're absolutely right, Chloe. So it makes it easier for seizures to occur in susceptible individuals. Yeah, that's exactly right.
Which is kind of what ECT, I mean, I know we're not talking about ECT today, but I mean, that's kind of when you're giving anesthetics for ECT, we're constantly tailoring the anesthetic that we give in order to elicit the seizure. So a lot of the medications we do impact that. So it's important to keep in mind how they impact the seizure threshold.
I'll tell you a little story about the last time I used Brevitol. And this is going to date me. This was in the 90s. And I was working as an emergency room nurse, and we would frequently use methylhexatol, Brevitol, to help reduce shoulders. So if a patient came in and they had a shoulder dislocation or a hip dislocation or something like that, we would use Brevitol for procedural sedation, and that would provide a very brief period where the patient was unconscious, and the ER physician or the orthopedic physician who was there would come in and reduce that joint that was dislocated. Well, this was right about the time that the ER started using Propofol. And we were really good at methylhexatol and Brevitol because we'd use it so much. And I remember the first time we used Propofol instead of methylhexatol, Brevitol, and we hadn't used it that much, so we weren't as familiar with it, and the patient went apneic. I remember having to bag the patient for several minutes, and everybody got really anxious, and we're like, all right, next time we're using Brevitol. And of course, now we use Propofol for everything. So I feel real comfortable with Propofol these days. But yeah, that was the last time I used Brevitol, was in the ER in the 90s.
Yeah, what's funny is that I always tell students, and this is like my new tip that I always tell students clinically and now in the classroom, is that you can't be good at things you never do. So going into clinical and just talking about your Brevitol versus Propofol story, like you were so comfortable with Brevitol because you did it so frequently, and then now we're so good at Propofol. So, I mean, clinically, it just boosts your confidence to keep that in the back of your head, you can't be good at things you never do. And as you continue to grow clinically and take all of these tidbits that we're giving you and stories into the clinical setting, you just grow in confidence and become a better provider. So just remind me of that.
Absolutely. And that's what I tell my students. You know, when you're in training, when you're in your clinical training, this is the time to try everything. Because you generally have a preceptor nearby or somebody nearby that can rescue you if needed. And there's also plenty of preceptors that do things differently. And so you can start to develop your own anesthesia aura or how you're going to do your anesthetic in the future. You take what you like and you leave the rest.
Yeah, definitely. So let's go into the pharmacokinetics of these drugs, since we've touched a little bit on their mechanism of action and how they work in the brain in the GABA receptors or NMDA receptors. So can you talk a little bit about some of the pharmacokinetics or side effects of the drugs?
Yeah. So pharmacokinetics in terms of propofol. We'll start out with that one. This one is a very highly lipid soluble drug, and it's going to rapidly go to the brain and establish large concentrations there, and that's where we need it to work on those GABA receptors. And it comes off pretty quickly because it rapidly redistributes from the central nervous system into the peripheral compartments like the muscle and the adipose tissue. And so that's why a patient can be induced under anesthesia, and 5 to 10 minutes later, they can start waking up if you don't provide any additional anesthesia. The elimination half-life is pretty short, anywhere from 30 to 90 minutes. Hugely protein bound, about 98% protein bound. It undergoes hepatic oxidation in order to be converted, and most of it is renally excreted. So that's pretty typical of these induction agents in terms of how the body processes them and then ultimately eliminates them. If we're talking about the side effects, so this is really the pharmacodynamics, how these drugs act on the different systems. And propofol, what it's going to do, obviously, because it works on that GABA receptor, it is going to cause, in the CNS, sleepiness, anesthesia. What it's going to do in terms of the vasculature, it's going to decrease cerebral blood flow, decrease intracranial pressure because of the decrease in cerebral blood flow, and importantly, decrease the cerebral metabolic rate of oxygen consumption. So we call this a neuroprotective medication. And indeed, in our neuro procedures, a lot of our craniotomies, when we're doing total IV anesthesia, we'll use propofol as our primary anesthetic in combination with other anesthetics. Benefit of propofol is that it has antiemetic effects. It's thought that it probably has a depressant effect on the chemotactic trigger zone in the brain. It also will depress seizure activity. So if somebody comes in and they're seizing, they have an IV, propofol, in addition to benzodiazepines or instead of benzodiazepines, can be used to help manage seizure activity. There is a phenomenon that sometimes can occur with the administration of propofol on induction, and it's called transient excitatory phenomena. Essentially, this is a brief period of really increased neuronal activity, and what you might see is something called myoclonus, which is a brief shock-like muscle jerk. So before you administer a neuromuscular blocking agent and you administer propofol, every once in a while you'll see the patient jerk a little bit, and that's a myoclonic type movement. And what this is thought to be caused by is a disinhibition of the subcortical areas. But again, I mentioned it's uncommon. All right, so that's the brain, the heart, and this is really one of the big side effects of propofol. It is a potent direct myocardial depressant, and it's dose dependent. So the more propofol you give, the more depressant effect you're going to have. It's also patient dependent. So if the patient has some kind of heart disease or heart condition, then propofol will affect them to a greater degree. It's also a potent vasodilator, and again, that's dose dependent. The more propofol you give, the more vasodilation you're going to have. So what's the result that we see on the anesthesia monitor? Hypotension. We generally will see hypotension after we give an induction dose of propofol. And so we're anticipating that when we give that. In terms of its respiratory effects, it is a very potent respiratory depressant, as I learned in the 90s with that shoulder dislocation. And so get ready to manage the airway when you are administering propofol. It has very minimal bronchodilatory effects. So you can give it for an asthmatic, but it's not going to result in any bronchoconstrictions. There's no histamine release when you give it. One kind of really odd thing about propofol, and I think you're probably more likely to see this in the ICU. I don't believe I've ever really seen it in anesthesia, is it can discolor the urine and cause it to be a green color. And I looked up the mechanism, and in certain patients, they're not entirely sure who. They have theories, but ultimately what they think happens is the liver will break down the propofol into various metabolites, and some of these are called phenylytic metabolites, so nobody needs to remember that. That's probably never going to be asked on anything, but that's what's thought to cause that green color in the urine, and it's likely as a result of a prolonged infusion. So that's propofol in terms of pharmacokinetics, pharmacodynamics. Should we talk about Etomidate next?
Sure, I can give a little anecdote about propofol and the hypotension.
Oh, please do.
I remember clinically the first time that I experienced or had a clinical scenario where I saw the baroreceptor reflex. I was doing an induction as a student and gave my propofol induction agent, IV obviously, and my preceptor was like, "Do you hear that?" And I was like, "I only could hear, like Sass always says, that my own heartbeat in my ears. Like I couldn't hear anything else. I was so stressed out." And I was like, "Hear what?" And he's like, "The heart rate. It went up." So let's check, like, cycle of blood pressure while we're doing all this. So as the propofol causes vasodilation, we have that baroreceptor reflex, and you can have that reflexive increase in heart rate. So
Yep.
kind of a tidbit on the first time I experienced the hypotension and baroreceptor reflex with propofol. So it definitely causes that vasodilation.
It sure does. And then you stick a blade in the mouth and you get even more tachycardia from the laryngoscope blade.
Yeah.
All right,
So
so
yeah, we can talk about Etomidate a little bit.
let's do it. Etomidate. All right. So again, this medication is going to work on the GABA A receptor, so similar to propofol. Etomidate acts as a sedative. They call them sedative hypnotics. The propofol, etomidate, a sedative hypnotic induction agent. You'll hear that a lot when we talk about these two induction agents. And so again, it's going to work on the GABA receptor and cause inhibitory neurotransmission. It's going to block, or it's going to enhance GABA and enhance that inhibitory effect that GABA produces in the brain. So more chloride ions are going to enter the neuron, again causing that hyperpolarization and an inhibition of neuronal firing. All right, so now here's the thing that differentiates etomidate from propofol. Etomidate is more selective at the GABA A subunits. And so it just FYI, it works more primarily on the beta subunits of the GABA A receptor. And this is probably why, and we're going to talk about this, that it is more likely to have a stable hemodynamic profile. So when we give it, we don't see as much hypotension as we do with propofol. And again, it's probably because of these specific GABA A subunit binding sites. Propofol, in contrast, has more of a broader receptor interaction at the GABA A receptor. So it's going to work on a lot more subunits. And this is probably why it is a deeper sedative. It will cause patients to have a deeper level of anesthesia. And it's probably why we have more of a cardiovascular effect or depressive effect. A couple of things about both etomidate and propofol, and I thought this was really interesting. So at lower doses, they will enhance GABA. So they'll just say, "Hey, GABA, we're sitting here on this GABA A receptor. Why don't you come and join us?" So the actual neurotransmitter, they'll increase its concentration. At higher doses, both etomidate and propofol, they can actually directly stimulate the GABA A receptor, even if there's no GABA there, and produce those GABA effects. So they do both. They bring GABA in, so there's more GABA at the receptor, and in high doses, they just act as GABA. And there's fancy words of what that is, and it's allosteric and that kind of thing, but we're not going to go into that today.
Yeah, and with Etomidate, we kind of talked about this earlier, but with the side effect, which I'm sure you're going to talk about in a minute, of adrenal suppression is the main reason why clinically I've seen it used a lot less. We used to kind of go to Etomidate anytime we had any indication for trying to keep a patient more hemodynamically stable, and we're kind of going by the wayside because of the side effects. Can you talk a little bit about the side effects?
Yeah, you're absolutely right. So when we give etomidate, primarily we're giving it, as I mentioned, because of it doesn't decrease the blood pressure as much. So if we're giving it for a patient who might have cardiovascular disease, and we don't want to decrease that blood pressure a lot, like we may if we would administer propofol. So that is one indication for giving it. And in terms of the side effects, that's the big one, is adrenal suppression. This is actually a major concern. So what's going to happen with etomidate is it's going to inhibit an enzyme in the adrenal gland called 11-beta hydroxylase. And this is an important enzyme that's needed to synthesize adrenocortical hormones, including cortisol. And cortisol is absolutely necessary. It's a stress hormone. The heart needs it for proper function. Acts as a positive inotrope. It's also necessary for vascular responsiveness. And so if we're inhibiting that because we're giving etomidate, then later on, we're going to have some problems with cardiovascular function. So there's actually quite a bit of literature out there and research out there now that we should avoid it in critically ill patients, especially those in shock states. Those who are in septic shock, we pretty much avoid etomidate now because of this adrenal suppression and the inability of the adrenal glands to synthesize cortisol. And here's the crazy thing. It can actually suppress the adrenal gland even after one dose. So even after one dose, that adrenal gland could decrease the amount of cortisol for anywhere from 6 to 24 hours, just depending on the patient's condition.
Yeah, which is, like I said, we just don't use it for that reason as frequently anymore. And as anesthesia providers, we're worried about getting the patient through the anesthetic, of course, but we're also looking at long-term morbidity and mortality. And I think that's where this kind of comes in.
Yep. And another side effect of etomidate is similar to Propofol, but I think even to a greater degree, is that possibility of myoclonus. So that jerky movement after you give it on induction, it's associated with about anywhere from 50 to 80%. So you're more likely to see that myoclonus on induction with etomidate than Propofol. Now, it can be decreased if you're pre-treating with dexmedetomidine or Versed or fentanyl. If you're giving that as part of your induction, you might not see the myoclonus as much. But the theory is the same. It's that disinhibition of subcortical structures. And we do tend to avoid etomidate if a patient has a history of seizures because we don't want to see that. Really not a lot about it lowering the seizure threshold. I'm sure it does to some degree, not to the extent of Propofol. Propofol is much better and benzodiazepines are much better at that. It does provide some neuroprotection, so similar to Propofol, it's going to decrease the cerebral metabolic rate of oxygen consumption. It's going to decrease cerebral blood flow, so there's going to be less intracranial pressure. And in terms of the respiratory effects, very similar to Propofol, it's a respiratory depressant, and so we want to be ready to manage the airway when we give it because the patient's going to stop breathing. One other important side effect is that it is more likely to cause postoperative nausea and vomiting than some of our other induction agents.
And the other one that causes that as well is ketamine. And I haven't really seen a lot of nausea vomiting using etomidate because usually those patients are so sick. It's more to the bottom of the totem pole in terms of the things that we worry about with patients that we're giving etomidate. But with ketamine, for sure, I've seen patients get sick with ketamine.
Yeah, and specifically with the induction doses of ketamine. So we'll talk about how we're going to administer all these drugs in just a little bit, but let's briefly go over the pharmacokinetics, pharmacodynamics. So in terms of the pharmacokinetics, what differentiates ketamine from the other ones is there's really no vehicle that's needed for administration when you give it. So when you give Propofol, it's in that lipid emulsion. When you give etomidate, it's called a fancy chemical name called carboxylated imidazole. And essentially it's the imidazole nucleus that allows for the lipid solubility so that the drug can be delivered and cause its effects in the brain. Ketamine, on the other hand, it does not. It does not require any kind of vehicle in order to reach its target receptors and then provide its effects. Ketamine works pretty quickly. The onset is within 30 seconds if you're giving it IV, whereas the IM onset is anywhere from 3 to 5 minutes. We don't give Propofol IM or etomidate IM. Those are strictly given intravenously. But ketamine, you could give intramuscularly. And again, the onset is pretty quick, 3 to 5 minutes. Now, the duration of ketamine is going to be pretty quick, anywhere from 5 to 30 minutes. And this depends on the route and the dose, whether you're giving it IV or IM. And similar to Propofol, it's going to have a pretty rapid offset. Patients can wake up after a single dose after about 20 or 30 minutes. So a little bit longer than Propofol, but it's still relatively short acting. And again, this is because of rapid redistribution from the central nervous system into muscle and fat. So similar to both Propofol and etomidate, it undergoes hepatic degradation. So that's a fancy way of saying chemical alteration of the medication. And this requires the hepatic enzymes. It's eliminated through the kidneys and in terms of its effects. So let's talk about the pharmacodynamics. With ketamine is going to increase cerebral blood flow. So that's different from the two we were talking about before with Propofol and etomidate. So ketamine actually increases cerebral blood flow. It will probably provide some degree of increase in intracranial pressure. What's interesting is if you're monitoring ketamine if you're monitoring the patient with a BIS monitor, ketamine doesn't really have an effect. It's one of those medications where you won't see a decrease in biz with administration of ketamine. So, whereas you will with Etomidate or with Propofol. And the biz is bispectral index monitoring. It's brain monitoring. It's one of the monitors that we can use in anesthesia to monitor the depth of anesthesia. But ketamine, really, when we give it, we're not going to see much of a decrease in that level. So we have to rely on other indicators to make sure that our patient's asleep. And we'll talk about this in a bit, but we don't typically use ketamine as an induction agent. There are a few indications, and we'll talk about those. But if we're looking at effects of ketamine, it causes that dissociative anesthesia. So again, it's that cerebral decrease in cerebral cortex function, but the increase in the limbic system, in the emotions. And you might see a patient who has something called nystagmus, which is a vision condition. And what happens is the eyes have uncontrolled repetitive movements. So they could go up, they could go down, they could go in circles. And so what's going to happen is you're going to see a patient who is just kind of sitting there. They may look like they're awake, the lights are on, but no one's home. That's probably one of the best ways to say it when you're looking at somebody who's on ketamine. There's another condition that can happen called emergence delirium. And I kind of mentioned that earlier. Again, it's highly variable depending on the dose that's given. So if you are giving an induction dose, it's more likely to happen where we have these auditory and visual hallucinations. The patient undergoes vivid illusions. I remember one time I had a patient, and I was in training. We always remember the stuff that we had when we were nurse anesthesia students, and I was working at a county facility. Well, one of the indications for giving ketamine is in obstetric patients who are undergoing cesarean sections, and you don't want to totally put them to sleep, but maybe the epidural isn't working that you're using as well, or the spinal hasn't gone up high enough, and so the patient is experiencing a degree of pain. And typically we want to keep our laboring mothers awake when they're having C-sections and when they're birthing so that they can see the baby immediately after. In addition, there's airway considerations with a full-term pregnant patient. And so we typically don't want to put them to sleep. So one of the things that we can do in order to help get the patient through the procedure is give little boluses of ketamine. Well, we were given boluses and boluses and boluses, and we tipped the scale at some point and in recovery, and we got her through the procedure. In recovery, she saw things crawling on the walls. She was hallucinating, and it took about 10 milligrams of midazolam, of Versed, to help calm her down.
Yeah, very interesting. I've never seen it clinically that bad, for sure. But yeah, I was said in another podcast, like we give 20 milligrams of ketamine, and then if they're kind of crazy in recovery, the nurses are always like, oh, it's the ketamine. And you kind of wonder, like, is it? Because it's such a little dose. But if you tip that scale, they definitely can have those kind of crazy side effects.
Yeah, and we're talking about induction doses, which is going to be more than 1 milligram per kilogram. 20 milligrams, very unlikely to cause these symptoms. Usually, if a patient is in recovery and they're experiencing those symptoms and you've only given an analgesic dose of ketamine, it's probably related to all the inhalational agent you gave, or the duration of the surgery, or the age of the patient, and all these other factors that come into play. So just to finish up the pharmacodynamics of ketamine, on the cardiovascular system, it acts as a sympathomimetic. So it's going to exaggerate cardiovascular effects. It can lead to hypertension, and this is because it indirectly releases catecholamines. But we got to be careful, because if the patient is catecholamine depleted, then we'll actually see some hype, and possibly we could also see some arrhythmias from the release of catecholamines. So an indication to give ketamine is if a patient is somewhat cardiovascularly unstable or in shock. I know they use this in the emergency department as an induction agent, because if there is catecholamines, endogenous catecholamines that the patient still has, they will maintain a blood pressure, even with an induction dose of ketamine. In terms of the respiratory rate, the respiratory system, this is also an indication to give ketamine. It will generally maintain respirations and maintain normal pharyngeal and laryngeal airway reflexes, which is a benefit if you're trying to manage an airway and you want to keep them spontaneously breathing to a degree. One thing to keep in mind, though, is that if you give a large dose, like an induction dose, and give it really fast, that will actually cause apnea in a patient for a short period of time, but it's still going to cause apnea. Another benefit of the pulmonary system is that ketamine is actually a potent bronchodilator. So we could use this in our asthmatic patients. The textbooks all say it, if you have an asthmatic patient who's experiencing an acute bronchospasm and you have to put them to sleep, then ketamine is one of the primary options for that.
I'll kind of summarize the three of those. So propofol, etomidate, ketamine. Propofol causes the hypotension metabolized by the liver. It does have the pain on injection as well, which you didn't really mention, but patients will definitely complain of that, which is why we give a little bit of lidocaine sometimes. But it has an antiemetic effect, whereas etomidate is more hemodynamically stable, but it does cause post-op nausea, vomiting, and the adrenal suppression. And ketamine has the dissociative anesthesia, can increase blood pressure and heart rate, but causes bronchodilation. So those are kind of just a little bit of a summary. So basically, Jeremy, we need to come up with an induction agent that has all of the good things and none of the bad things. And then we can just teach for fun.
Exactly. And just to kind of go with your point of pain on induction, propofol, definitely. Especially in those small vessels, they have a lot of nerve endings inside the veins, and it's how the propofol is suspended in that lipid phenol vehicle, and that's what causes the pain. One other consideration, etomidate. Etomidate can cause major burning. The older preparation used to combine it with propylene glycol, which is what caused it to burn so much. The newer preparations are more of a fat emulsion, which burns less. They both, etomidate and propofol, can cause burning when you inject them. And so we typically will give lidocaine before both of those. I do always recommend to my students that I do not mix the lidocaine in the propofol. I'll have them in 2 separate syringes. So that way you always know the exact dose of the medication you're giving.
I'm the same way. It's so funny how we have our little quirks. Knowing exactly the dose you're going to get is very important. So let's kind of talk about patient considerations and apply this clinically. So how would you choose which agent to use in different patient populations?
Okay, so propofol, that's our workhorse. That's our go-to. I use propofol every day I go to work and I go to the OR. It's great. It's fantastic for smooth IV inductions, and also for either, if you're, like I mentioned earlier, if you're doing a total IV anesthetic, it's great as an infusion. It's great as a supplementary infusion. Sometimes I'll run a little bit of gas and an infusion of propofol, and it works incredibly well in stable patients. We get a fast recovery. It's got those antiemetic properties. We know, we use it so much in anesthesia, it's all dose dependent. We know how and when to use it. The big caveat is unstable patients. We're going to be very, very careful in hypotensive patients when we give propofol. Ketamine is great for our hypotensive patients as an induction agent. Or so for example, in the ER, somebody who comes in with trauma and hypovolemia, ketamine would be a great option. It's also great, as we mentioned, for our patients who have acute bronchospasms and we have to put them to sleep. Etomidate is ideal for those patients who maybe I shouldn't give propofol to them because they have a history of cardiovascular instability or cardiovascular disease. Those would be the patients that we might consider giving etomidate to as an induction agent. But we're certainly going to avoid those in any patient who has septic shock or if they have any inkling of adrenal suppression.
Yeah, and sometimes it's kind of a game time decision. I was just recently clinically had a patient come that was in the ER, pretty hemodynamically stable, but bleeding, ended up coming to us, and the first blood pressure 80/50. We're like, okay, so now we're switching the induction agent over to etomidate because of this clinical picture. So sometimes it takes that game time decision to decide which induction agent to give.
Sometimes it does, absolutely.
I think it's important too to kind of apply this clinically as much as you can as students, because it's not just memorizing facts, right? So you can memorize all of these things and the 11 beta hydroxylase, like all of these little key terms that you will be tested on, right, and need to know for boards. But it's so important to be able to apply it clinically, which is kind of why we're telling you little stories along the way of things that we've experienced as providers. So again, do you want to talk about the literature, Jeremy, with some of these induction agents, or what do you think?
So yeah, we've talked a little bit about the literature in terms of the adrenal suppression with etomidate. One interesting thing, I thought this was kind of interesting. So have you ever combined ketamine and propofol to use as an induction agent or anything of that nature?
I have not personally, but they call it white lightning, right? I've never done it.
They do. I remember hearing that from a fellow student in my class, and we were rotating through the different clinical sites, and we always loved coming back to class. The program we were in was integrated, so we were still in class one day a week, and then we were in clinical all the rest of the week, and so we would always look forward to that day in class, and we'd talk with our friends, be like, well, what cases did you do? And this is what I saw, and this is what I did. And I remember one of my fellow classmates, Paul, came and said, I used white lightning. And I was like, what's white lightning? Some people will call it Ketamine. So there is research out there of its use. So some of our listeners may hear that and they may see that. There was a study in 2018 about its use, the effectiveness, and this is the name of it, the effectiveness of Ketamine versus Propofol induction on hemodynamic profiles in adult elective surgical patients. It was a randomized controlled trial. And I'm sorry, I said 2018, it was 2021. They saw that there was maybe a slight improvement in the hemodynamic profile with the combination of ketamine and propofol. And they give specific doses in that study, but it's worth a read. It's interesting. So definitely something to check out.
Yeah, I'll have to look at that because, I mean, I'm always trying new things with Precedex and the new medications that we give. And that's the benefit of this, and the literature that you can dive into is seeing how they can be used effectively together because they have that synergy. But like we talked about with the NMDA receptors of ketamine and hemodynamically increase the sympathetic nervous system, we can kind of balance the yin and the yang, like Sass and I talked about a lot of the time. Using them together can be even more beneficial to patients. So I'll have to check out that study.
Yeah, absolutely. And I know you did a podcast with Tom about opioid sparing type procedures. And yeah, we dexmedetomidine, ketamine, propofol, they're all involved in that. And if you give a lower dose of several different medications where you're targeting different receptors, you're going to get a really good outcome. Because I've used some of those techniques and it works really, really well in terms of the anesthetic during the procedure and as the patient's waking up after the procedure.
Yeah, I still have to go back and re-listen to that podcast with Tom and write down all of his tips and tricks. He was doing it so fast with all the dosages because the more you do it, the better you become at it. And so he does it all the time. He can riddle off all these dosages. And I was like, okay, I'm going to have to put that in my little notebook. So we're going to kind of go into, if you can tell us, we've told stories along the way, but is there one example of a time where you had an induction agent that either surprised you or you had a side effect that was very obvious? So you've told a couple stories already like this. But just to kind of help the students remember any key component of any of these induction agents.
Yeah, well, certainly that story I told about the ketamine, and that was an induction dose. I did want to mention that I use ketamine all the time in anesthesia practice, but I primarily use it as an analgesic medication. It all depends on the dose you give. And so if you're giving very low doses of ketamine, and we're talking like 0.1 to 0.2 milligrams per kilogram, and if you give that, you're just going to hit those NMDA receptors, and that's going to help with a degree of pain management. And rarely will you see the side effects. I think one important side effect that we did not talk about in terms of ketamine and using it as an induction agent is that it will increase secretions in the airway as well. So with that large dose of ketamine, you'll have hypersecretions, and so you want to be careful if you've induced the patient at the end of the procedure and you're going to extubate them. Make sure you suction them really well because it could precipitate a laryngospasm, and I have seen that after large doses of ketamine, so we want to be careful of that. One thing I'll say also is that I always have propofol ready to go. Propofol is if you need to put a patient to sleep really quickly, or let's say they get light under anesthesia, you need to get them down really quickly, propofol is the go-to. Propofol is what I'll reach for, so I always have some immediately available in case I need to get a patient under a deeper level of anesthesia really, really quickly.
Yeah, I remember one of the clinical coordinators at the facility that we worked at, that she told me as a new grad, she was like, always have a stick of propofol. Because you're learning how quick the surgeons are, you're learning a lot about your own practice. Like that is something that I've always kept with me, and she told me that. So anyone listening, it's a great little advice.
Absolutely, and you can give it, and it wears off pretty quickly. So you're not going to be
you're not stuck with it forever.
Fast. You're not stuck forever.
Yep. Okay, the last thing I'm going to ask you, Jeremy, I'm so appreciative of all of your time, that I ask everybody on this podcast is, can you give us one piece of advice or encouragement to anyone that is currently in anesthesia school?
Yeah. Well, what I would say is just remember that feeling when you got accepted to anesthesia school. Remember that feeling, and just knowing that your life was going to change and you were so excited to start and to learn things new, and just try to remember that feeling as you're going through school. It's a tough journey, but it's supposed to be. There's no way that you can make that transition from ICU nurse to CRNA without it being difficult. It has to be difficult in order for you to transform. And so along the way, just try to remember that feeling of when you first started and that excitement. And maybe that's something that will help you in those long nights of studying, those long days, and sometimes long nights of being in the OR. Just remember that you're there, you're doing it. I can't tell you how amazing this job is. I've loved every day. Now I've been in anesthesia now for 21 years. Again, that's going to date me. I sound like an old dinosaur. But I've loved it, and I would not trade it for anything.
Yeah, it's so true to think back to that. And it reminds me of our first cohort for the faculty that I'm a part of now. We got to call, our program director wanted us to call each applicant to let them know before we sent out the letters. And I was like, okay, are you driving? You got to pull over, because these applicants were so excited. And so that's something that I'll keep with me as I'm encouraging them along the way and advising them through to the finish line, is that excitement, because I actually got to hear it. So we know that you guys were excited at one point, even though it may seem bleak on some days. Well, Jeremy, thank you so much for being here. We are so grateful for all of your knowledge, and we'll have to have you back for different topics.
I would love that. Thanks so much, Chloe. I've had a great time.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.